Okay, let me just show you this case history he just mentioned. So this is almost a routine patient whom we see in our clinical practice. Diabetes is so common, no matter where you are practicing in India. Patient had a critical lesion, and I suppose he underwent angioplasty following this. He has a strong family history because CAD in a younger brother. LDL is 112, and triglycerides are elevated, but I wouldn't give too much importance to the TG here because he has uncontrolled diabetes, and therefore I would say if you control it, the TG would come down. So the emphasis should be on the statin, should be on the LDL, because he's already getting 20 milligrams of rosuvastatin, which is a good dose. It is considered as a high dose high dose statin. So what do you think of in this patient? Look at these relatively recent guidelines from ESC-EAS published in 2019. So if you see here, as the risk of the patient rises from less than 1% to more than 10%, the goalpost is absolutely moving farther and farther. While at a low risk, a level of 116 is okay. At very high risk, a level of 55 milligrams has to be maintained as per this guideline. So it is important for a patient like him, who is a high risk patient, that you should really bring down his LDL to 55, while it is right now it is 112. So what drug you will use? So if it is very high, it is 55, and if it is high risk, it is 70. And if all of you remember, the Lipid Association of India has been crying hoarse that it should be 55 or less for quite some time, and ESC and ACC came out with this kind of statement much later. Okay, so you have today extremely good drugs available in our armamentarium. A moderate intensity statin will bring it down by 30%, high intensity statin by 50%. If you combine it with ezetimibe, it comes down by 65%. If you give PCSK9 inhibitor, it will come down by a whopping 75%, and all three it will be 85%. Being a relatively frequent user of PCSK9 inhibitors, I know that it really brings down LDL very, very low, and probably that's what it should be. Just now you have seen a debate where the surgeon versus interventional cardiologist have spoken about what is done at the time of the procedure. But what is equally important in the long run is to bring down the LDL, bring down the A1C, bring down the blood pressure, and that is probably as important or more important than the mechanical part of the treatment. Okay, you have very good data also today. If you bring down the LDL by 1.07 millimoles, which is approximately 44 milligrams, there is a whopping 22% risk reduction over course of time. That has been shown by so many trials, starting from the old trials to the latest trials. So you have drugs, you have evidence. So what is holding us? In real world, this is a relatively recently done trial called the Da Vinci trial. It is done in about 18 countries across Europe, and they showed that LDL level of less than 55 post MI is achieved only in 18% of the population. So that's a very, very small figure. That's a sad figure. Why only 18% when you have the drugs, and European population, they hardly pay for their drugs, unlike India. Everybody gets the medications from the governments of their country, and yet the target is achieved in only 18% of the patients. One of the important reasons for not achieving the target is, of course, the ignorance on the part of the patient, certain degree of slowness on the part of the physician. But a very important thing is the statin associated side effects, most importantly muscle symptoms. We all know, those who have been practicing for a while, we know that patients do have considerable muscle symptoms like muscle pain, myositis, and in a rare case going to rhabdomyolysis, and therefore the muscle symptoms do play a certain role in us not achieving what we want to achieve. Now in this particular data, you can see even among patients post myocardial infarction, 57% are not fully adherent to therapy after 6 months. They initially take the drugs as you advise, but within 6 months, a lot of them either give up for one reason or other. The fully adherent are only 43%. The non-adherents are 26%, and partially adherent are 31%. And we know that if you bring down the LDL and keep it low, the event rates will come down significantly and remain so. Adherence to therapy can be essential to prevent another event. So which drug would you use here? So you have statin, you have PCSK9 inhibitors of one type or other, ezetimibe, and now the latest entry into India, the bempedoic acid. So what is bempedoic acid? This is a drug which is a drug that acts on the cholesterol biosynthesis, 2 steps proximal to where HMG-CoA reductase inhibitors act, namely the statins. So it is called ATP citrate lyase enzyme inhibitor. It inhibits cholesterol synthesis in the liver. It increases LDL receptors density just like statins. In addition, very importantly, it activates adenosine 5 monophosphate activated protein kinase, which goes on to inhibit gluconeogenesis and suppresses the hepatic production of glucose. Unlike statins, which actually worsen the chances of a person getting diabetes or worsening his diabetes, bempedoic acid actually improves the situation. So this is the mechanism of action of bempedoic acid I already mentioned. ATP citrate lyase is inhibited, and the drug actually is a prodrug, bempedoic acid. It gets converted to active form in the liver. The enzyme which converts it is there only in the liver but not in the muscles, and that is supposed to be the reason why muscle symptoms are not there. The bempedoic acid cannot act in the muscle. And as you see at the bottom, AMPK activation leads to reduced levels of glucose, and if you have a patient who is borderline diabetic, slightly elevated A1C, but it is still a pre-diabetes, and situations like that, bempedoic acid may be a better alternative to statins for reducing the LDL levels. Okay, so here is a comparison of the various drugs today available: statins, bempedoic acid, ezetimibe, PCSK9 inhibitors. Bempedoic acid is ACL inhibitor and thereby cholesterol synthesis in the liver. It is a orally given drug. It is given as 180 milligrams in the night post dinner, just like statins, and half-life is 15 to 24 hours. If you give only bempedoic acid, it reduces the LDL levels by 17 to 18%, little less powerful than statins. But the moment you combine bempedoic acid with ezetimibe, it comes down by 38%, and the combination has not been shown to increase the side effects of either of the 2 drugs. The problem with bempedoic acid are 2. One is hyperuricemia. It's the glucuronide metabolite of bempedoic acid interferes with the excretion pathway of uric acid, and therefore it raises the uric acid levels in the blood and resultant slight increase in the gout. It also produces a slight increase in the serum creatinine, which is reversible the moment bempedoic acid is stopped, and for some reason it tends to produce slightly higher incidence of tendon ruptures, usually involving the shoulder or biceps or the Achilles tendon. Low incidence but higher than the incidence in the placebo. You can see here hyperuricemia and gout are slightly higher compared to the placebo arm. Another side effect seen with bempedoic acid is mild anemia, the mechanism of which is not very clear. Now I'll just take you through a couple of important trials. There are 4 big trials done with bempedoic acid for looking at the events as well as to see what is the effect of this drug on LDL, and these are called the clear group of trials: Clear Harmony, Clear Wisdom, Clear Tranquility, Clear Serenity. The right side 2 trials are trials done in patients who are statin intolerant, and therefore the level of reduction of the LDL is far greater. The left side group are the 2 trials in whom statins are already given to the highest dose possible, so the fall is little lesser. Clear Harmony is the trial which is a big trial of 2,300 patients, and it shows that the LDL levels will come down by about 4 weeks and remain so over course of time. It also reduces total cholesterol, non-HDL cholesterol, and ApoB. Triglycerides actually slightly increase. So for a patient like this, there is no special advantage as far triglycerides are concerned, but the triglycerides in this given patient are probably is due to the fact that diabetes is not controlled. Non-fatal myocardial infarction also comes down, as you in almost all the meta-analysis combining the patients from different trials. It is clearly shown that non-fatal MI comes down with bempedoic acid. A new onset or worsening diabetes also comes down. You can see here BA. There is another meta-analysis which showed that bempedoic acid is associated with lower risk of CV mortality and diabetes mellitus. Clear Wisdom trial as well as clear harmony showed that CRP levels come down. Bringing down CRP, which is otherwise called pleiotropic effect of statins, is actually also shared by bempedoic acid. Significant fall of CRP, hsCRP. But unlike statins, bempedoic acid actually reduces the chances of new onset diabetes or worsening of the current diabetes. I'm almost done. One moment. Okay. So, therapeutic options after maximally tolerated statins, it may be any of these drugs. And where do we bring in bempedoic acid in these patients? So it can come at this level, that patient is just not able to tolerate statin, and therefore you quickly go to bempedoic acid. It may be also that you are given the best possible other drugs and still you have not reached the goal. Then again you may have to go to the bempedoic acid, or as a combination with ezetimibe following statin failure. So the trial that is awaited, the event-based trial, is called the Clear Outcomes trial, and its patients are going to be on follow-up for nearly 5 years, and the data is expected sometime late in this particular year. All right, thank you very much.
Friends, it's a proud privilege to be here in Ahmedabad again. Just had come over 2 months for a similar session, and must really congratulate Dr. Kamal for the Kamal he has done. Even yesterday, the digital, I had sent it to many of my PG students, and they were glued, and I too could attend certain important sessions. And today also, when I saw, there were people waiting outside the hall, which is something a rarity nowadays. So my topic, which I said earlier, is now the case we have seen. A young person has already been alluded by my friend Sarat, who already has NSTEMI family history, because younger brother has got a mixed dyslipidemia. He is diabetic, and we are going to see what best we can do. So here, when we were talking of various colors, so I was so confident, I said, give them all the colors. I will fight them alone. And the one is the blue one given to me. So this is a statin loaded patient, and then there are others waiting. Bempedoic acid dena hai, ya ezetimibe dena hai, glitazar, PCSK, fibrates. And look, there is a smart lady behind. He says, lifestyle modification, leave him alone. She will come back in the concluding slides. So in such a case, what should be the ideal target for cardiovascular risk reduction? Only LDL, only HDL, which is also low. Triglycerides are also high. As I said, he is a mixed dyslipidemia while on 20 milligrams of rosuvastatin. And what about ApoB and LP(a)? So what is new in dyslipidemia has been seen. So statins are, and they have become the hallmark of therapy in all cardiovascular diseases, dyslipidemia, ischemia, ASCVD. But in spite of adequate doses, 40% of the patients still experience cardiovascular disease. And neurotherapeutic agents to tackle such residual cholesterol risk is not only to tackle LDL-C, but even TG and triglyceride-rich phospholipids. That is what we are talking of, ApoB, which is an indirect measure of high-dense LDL. LP(a) are being introduced, and these are the various drugs. You see, if you see all, this was the latest summary of clinical trials, which has come 2021 in trends in circulation. The important drugs which have made the mark initially were started with high density statins, then comes ezetimibe. I'll not go into the details, and then followed by PCSK, monoclonal antibody, evolocumab, curomab, Ripata, and newer drugs like inclisiran, and even finally bempedoic acid. But look at the sample size. In case of ezetimibe, in IMPROVE-IT in ACS, 18,000, in the ezetimibe, which was the CKD, 9,000, but in Clear Harmony, only 2,000. So that is important. The duration of the trials in ezetimibe were 6 years, 5 years, whereas in case of bempedoic acid is only 1 year. And the cardiovascular safety outcomes are yet to be proven. So it is not just bringing down the LDL, but is it going to be beneficial? This is the pharmacological style, which I will tell you, it basically reduces the cholesterol absorption. Dose 10 milligram daily without food, very simple. very reasonable and cheap. The mean reduction with monotherapy is 18%, and with incremental doses of statin it goes up to 25%. And by and large, except for moderately severe hepatic impairment, there is no real contraindication, which is not a problem in Gujarat because alcohol is banned. So it shouldn't be worrying you, I suppose. And cases of myopathy and rhabdomyolysis have been reported, but then these are again very infrequent. Very few drug interaction, which is there with most drugs like cyclosporin. Sometimes you have to be careful with fibrates. So the cardiovascular outcome trials, today any new drug, whether it be SGLT2 receptor blockers, it be ARNI, it may be the statins, you have to show that it benefits and doesn't worsen. So here there is an incremental lowering of LDL in both the Improve It trial, which was focusing on the ACS patient, and the SHARP trial with ezetimibe in patients who had non-hemorrhagic stroke and even other arterial revascularization, and these are the patients with CKD, and these are all tolerated. So basically, what is your level? When you have seen the patient, usko kis category mein dalna hai? Lowering LDL by 38.7. Now what is this 38.7? Not a magical figure, it is 1 millimole, which is 38.7 milligram. If you give it for 5 years, it will reduce your chance of heart attack by 22%. If you give it for 12 years, it will reduce your chance of heart attack by 32%. And if you give it for 52 years, it will reduce the chance of heart attack by 53%. So that is what, when the previous speakers were debating whether lima dalna hai ki stent dalna hai, we are only putting the mechanical part and forgetting the most important part. So whenever you are giving a drug, it is equally important how long you have to give, and that is what the cost matters, the compliance matters, and the drop matters. What about triglycerides? All of you, there are many students I see here. For the Indian population, triglyceride less than 100 milligram is preferred, and 150 is the normal, should not be more than 150. And lifestyle interventions are also very effective. Now this is a very important slide which should be there with every physician. You can download it on Lipid Association of India. Now this is very important that today we are talking of the ACC guidelines, the European guidelines, the Canadian guidelines, the British guidelines. In America they don't talk of the European, their insurance will only cater to the American guidelines, and so on. In Europe they will not, if you treat as per the American guidelines, they will not insure you. So we have formed our own guidelines, and surprisingly we have found that there are differences in our culture as compared to the others. So today our patient fits into the extreme risk category type A. So here in previous guidelines they had a low, moderate, high risk, very high risk, but this has been accepted as the extreme risk category, which now even the International Society of Atherosclerosis has accepted, and after 2 weeks I'll be presenting this thing in New Orleans along with the parallel ACC. So you see, this is what you should be having, all of you, in your mobile, and these are the risk markers. So our patient has got already a ASCVD, he has got a family history, he has got a low HDLC, and if you see all these categories, if you fill them in, he comes into the category of extreme risk category A. The worse than that is category B, where in spite of the best treatment, he keeps on getting recurrent ischemia. So when you see this type of a patient, what are your treatment goals? Your treatment goals in extreme risk, the LDL should be less than 50, and optionally it should be even less than 30. Nothing short of that. Don't be satisfied if your LDL is 60, and that anything beyond, and the non-LDL should be less than 80. This is usually 30 milligrams more than the values in all categories. Now, what about ApoB? ApoB are not a treatment target for the mild to moderate. But if you are a patient with the extreme risk group, then even the ApoB has to be treated, and extreme risk group, the ApoB should be less than 50. So this is important. So the goals are there to achieve the LDL, non-HDL. Non-HDL is a co-primary target, and ApoB to be achieved in high, very high and extreme risk, as I mentioned, and then keep HDLC high with dietary modification, even though this is not a target. But 2023 guidelines we might change. So these are the studies of Utopia, where they found that first time when adding simvastatin did make a difference as compared to the control group. There was a reduction in the composite of atherosclerotic cardiovascular events. Most important trial was PROVE-IT, where 30% of the patients were STEMI less than 10, and these were very high risk patients, where it was added to simvastatin and compared, and there we found that there was a definite 6% relative risk reduction, and the number needed to treat was 56, which was quite appreciable. Now today when you see a patient with such type of cases, this is a similar slide already shown by Sharat, that you have to always start high intensity statin, atorvastatin, rosuvastatin. It will bring down your LDL by 50%. Add ezetimibe, it will bring down by another 20% per se, and PSK will bring down maximum by 60. But how many of them are going to take it lifetime? And if you add a combination of statin ezetimibe, this 50 plus 20 becomes 65. If you add a statin with PCSK is 75, and add ezetimibe. See, in all this, always a statin, next comes ezetimibe, and then third comes PCSK. That is important. Even in the European guidelines in the acute phase, they always say start with maximum doses of statin, and then you can add, if the levels are not controlled, add even in the acute phase ezetimibe, PCSK, and at discharge. So ezetimibe is very commonly, it is a very cheap drug, and other drugs which are fenofibrate niacin have not even shown any mortality benefit or cardiovascular safety outcome. The lower is always better, and even 53 is better than 70. And if you see most important trials, PROVE-IT is as comparable to high density and in with evolocumab and erokumab. These are the PCSK. So these are the drugs, and it is basically a drug which reduces the absorption, and even it is useful. This slide says in diabetic patients also it is useful, and it is so now what is important is what is the number 1 year number needed to treat to prevent one event with ezetimibe is 1 in 124, and that with evolocumab Repata it is 104. So there is very little difference, but look at the cost difference. Today even Mr. Gautam asked me, can he shift from Repata to ezetimibe? I'm talking of Adani. I said, I'll tell you after the lecture. So it is not that you have given once, you have to take it lifetime, and look at the cost. So to concluding slides, though it is ASCVD is a very high risk of clinical ASCVD, and then we should add ezetimibe PCSK. Bempedoic acid is still not included. I'm sorry for my friend Saruk Letazor, though I'm a proud Indian, there is no mention because we do not have adequate safety data on cardiovascular safety of a higher magnitude. These are the prices which might differ a little here. And so to conclude, it is widely used, it is efficacy at par, and there is no long-term safety concern, dedicated cardiovascular outcome, economical, well-established data in the case we have discussed, and no slide, no talk on lipid should go without lifestyle modification. But the unfortunate part is, this is a fitness gym where everyone is going for treadmill, but they are using the escalator, not the staircase to walk, because there they want to use the treadmill inside. And this is the doctor who had told him to spend 1 hour on the treadmill. That is how he spent. So the lady who you saw, who said lifestyle changes, in reality, this is the queue outside, pills and surgery. Lifestyle changes has got no takers. This is a picture which was clicked by Dr. Sarat when he was coming from Hyderabad airport. A lady he saw, and he gave it to me. I said, is this going to be India's future? I said, not if you give bempedoic acid. She will have so much of uric acid and joint displacement, she will not be able to carry all this. So friends, thank you very much for patient hearing. I tried to make it. It was post-lunch, so very difficult. So all statins, do they look safe? They look outwardly on the face of it. But then when you go in for data analysis, the prognosis would change. Thank you very much.
Thank you, Kamal, and thank you all the delegates and my co-speaker. As I think Dr. Vijayan said, like Saruk Letazor still not been mentioned because it's a new drug, so it will not be mentioned. Number two, before I start, let's go and look at the history of the patient, because I've missed the target line in this particular discussion. Important thing, that patient is a diabetic patient. That is number one. Number 2, patient has CAD. Number 3, patient has the profile, lipid profile which has been given. So probably the target what we have missed over here is that patient is a young diabetic, has a CAD, family history. Patient has diabetic dyslipidemia, which everybody has missed, because which constitute of high triglyceride and low HDL and a small dense LDL. So, and patient is on fairly high dose of statin, and sorry to say that patient has a fairly controlled diabetes. Patient is not a totally uncontrolled kind of. So my previous 2 speakers, they have absolutely missed on the target, that they have targeted only and only the numbers. They want to just bring down LDL for some reason, but they have missed that this patient has a diabetic dyslipidemia, which has to be treated with appropriate kind of a drug, and we are lucky to have that kind of a drug which has been available to us. This is a kind of an Asian phenotype. Typically what you find is a thin fat Indian, high visceral fat, higher insulin resistance, high inflammatory marker, high small dense LDL, early beta cell destruction, early onset of diabetes, higher risk of diabetic complication, high risk of CVD. So basically we have to understand that what we are dealing is something like this. And this is what the ICMR in that study has shown, that low LDL, which is pretty common amongst the Indian subset of patients, almost 72%, they have low HDL. Again, if you look at the triglyceride, 30% they have higher triglyceride levels, and the LDL level which is around in 12%. So what is the kind of a pattern and prevalence of atherosclerotic diabetic dyslipidemia? We have to understand over here that it is high TG, high LDL and low HDL. And typically if you look at this patient, has probably each and every part of atherogenic diabetic dyslipidemia. And again, like almost you find 34% of Indians, they have commonly this kind of condition when they have type 2 diabetes, and people who have a higher level of HbA1c, more than 8%, the incidence goes up to 73%. So it is pretty high. And we have been talking about reducing the LDL. Again, if you look at this figure or this study which has published, it has shown that in spite of using the high dose kind of a statin, simvastatin, atorvastatin, there's still a huge amount of residual risk which is being left. So even if you make LDL 0, patient is not going to be benefited by not having cardiac disease in his life. He is going to have cardiac disease because it's a progressive kind of disease, and that will be happening. So now let's understand why it is important, why triglyceride and the CV risk is important, which everybody has missed the point upon that. This is a Bari 2D study which typically has looked at patient with type 2 diabetes and CAD with the baseline TG of 180, and they looked at the composite outcome of CV death and MI stroke, and the secondary outcome of CV death. And this is a typically with a higher TG was associated with higher risk of CV risk in diabetic patient. And this is typically, you see over here, there's increased risk in all the kind of models what they have for the CV risk and for the CV death, MI and stroke. Even if you look at the LDL cholesterol in this pretty study, you find that in no event and the people who had event, the amount of LDL cholesterol is almost same. The p-value is insignificant. But if you look at the triglyceride, values are very much different in people where the events were there and no event were there. So it is very important that you should not neglect triglyceride in all such kind of conditions. The second important part what comes is the insulin resistance and diabetic dyslipidemia. Because when we are treating a diabetic patient, all type 2 diabetic patients will have some or more amount of insulin resistance. And why insulin resistance is important? Because insulin resistance will increase your lipolysis, it will increase free fatty acid, and that will be the basically the substrate for all different kind of lipid abnormality what you are getting in the blood, increases inflammation, and all your triglyceride, LDL, VLDL, everything will be get increased because of that. And everybody knows about this YY paradox where Yudkin and Yagnik, they have their Dexaton, and you find that more amount of fat in Indians. So more fat, so more free fatty acid because of insulin resistance. And if you look at the insulin resistance among Indians, you find that it is quite prevalent. Almost 35% at young age will have insulin resistance. Insulin sensitivity is pretty low. So we have to understand the pathophysiology in this kind of a diabetic patient, that why a diabetic patient got CAD first of all, and what should be done for that. So atherogenic diabetic dyslipidemia and the role of saroglitazar, which is the first new clinical entity. And if you look at this, you find that you have various kind of a treatment for a diabetes, and for a dyslipidemia, you have statin and fenofibrate. These are available kind of a treatment. But which of this drug is going to take care of both the things, insulin resistance and the root cause of diabetic dyslipidemia? So PPAR gamma probably had a good role in treating both. And again, like if you look at the newer development, where you had a dual blocker. So it was been approved in 2013 by DCGI for treatment of diabetic dyslipidemia. But over a period of time, it has become much more important because it is also useful for type 2 diabetic NAFLD, where you don't have multiple options for treating that kind of a condition. The dual receptor blocker, alpha as well as gamma, and this is how the dual receptor is basically going to act, because it is going to increase the fatty acid uptake, increase the fatty acid oxidation. So all those things are going to be beneficial. And ultimately, if you look at the effect of saroglitazar, you will find that it reduces triglyceride and non-HDL. So, and the PPAR gamma will improve the insulin sensitivity, and that again will have a kind of effect, beneficial effect on adipocyte and muscles, and which will take care of your basic disease what patient has, that is diabetes. These are the data about insulin resistance. Probably again, you have a single center randomized trial for 16 weeks where 30 diabetic dyslipidemic patients with hypertriglyceridemia were included with hyperinsulinemic glycemic clamp, and you find that there was at 4 months significant improvement in insulin sensitivity as well as the glucose metabolism improved at 4 months. These are the figure where you can see there's improvement in the blood sugar level, improvement in HbA1c almost about 1.3%, insulin sensitivity index, which can be measured by HOMA-IR. Again, there's a definite improvement is there, and overall you can see that not only diabetes, but there was improvement in the triglyceride levels, which was being seen along with that. So saroglitazar has been studied for multiple factors, and it has been found that it helps in reducing triglyceride almost 45 to 60%, non-HDL 21 to 36%, a small dense LDL by 20%, HbA1c improvement by 0.7 to 1.6%, and liver enzyme improvement by almost 28 to 67%. So in multiple studies, this is the abstract from 18 clinical studies, more than 5,000 patients. It shows that benefit at multiple fronts, not only one front, multiple fronts. And this is about the Indian atherogenic dyslipidemic patient, and where 150 patients, and you find that 4 milligram of saroglitazar being used at 12 weeks, and at 52 weeks you can see there's a significant reduction in the TG, almost 60% to 66% kind of a reduction, which has been seen at 52 weeks, which is a great benefit, which probably we miss it. Fenofibrate, which has been commonly being used drug, and there has been comparison with that, and here you can see that even with the fenofibrate reduction of around 41%, with saroglitazar almost 55% reduction at 12 weeks, which was been noted. It has been approved by RSSDI 2022 guidelines, where when the triglycerides are high, saroglitazar can be used in people who are at moderate to high risk of CVD. So just to conclude a few things, it was being thought that diabetes is going to kill by diabetic coma, but diabetes kills patient by dyslipidemia, and which leads to coronary artery disease. So what we need to do is we need to treat the pathophysiology of disease, not the number of your LDL or anything. With this, look back to the patient, and probably if you look back to the patient, you will find that in this particular patient who has typical diabetic dyslipidemia, your treatment of choice should be saroglitazar. So to summarize, in Asian patient, there is an increased risk of insulin resistance as compared to Caucasian, and a target of insulin resistance should also be done in all diabetic dyslipidemic patients, and the elevated triglyceride has a higher prevalence of atherogenic dyslipidemia and NAFLD, and saroglitazar is a molecule which will target both insulin resistance as well as hypertriglyceridemia in such kind of patients. Thank you.